Good afternoon, and welcome to the last webinar of ANAwareness Week 2022. The team at The Ohio State University Wexner Medical Center has given us an exceptional series of presentations this week. We've discussed multidisciplinary care and radiation, hearing rehabilitation, facial nerve reanimation, and surgery in the patient-provider experience. Today, we're discussing balance with Dr. Matt Bjelac and Dr. Greg Wenger. Dr. Adunka and Dr. Wren, Dr. Wren for right now, hopefully Dr. Adunka, are back to provide their expertise, and we're happy to have all of them here. Welcome, doctors. We'll start with Dr. Bjelac and Dr. Wenger's presentation, and then move right into patient questions when they're done. Doctors, I'd like to thank your entire team for the time and effort put into these webinars and for your thorough answers to all of our questions. I also want to let patients know that there are many resources available on our website for both pre and post-treatment patients. So take a look around at anausa.org. And if you need any help at all, please feel free to contact us directly, either through email or by calling our office. Okay, before we get started, I want to review how our presentation will work today. All of our attendees are muted, so you are only able to listen. If you have questions during the presentation, click the Q&A button in your toolbar and type your questions there if you're on the webinar, or add them to the comments section if you're watching on Facebook. There should be captions at the bottom of your screen. If you don't see them, click the captions button in your toolbar to activate them. If you're watching on Facebook, they should already be there. You may have to look in your settings if you don't see them. We are recording this presentation and we'll house it in the presentation section on the ANAwareness Week page. All of the webinars from this week are already there and ready to view, and we'll get this one up there as soon as we can once it's over. They're also on the Facebook page, and we'll add them to the video library on our website. There are lots of ways to get involved in Awareness Week. We have today and tomorrow yet to go. Visit our website and click the slider on the homepage to find everything you need to know. With that, I would like to introduce Dr. Adunka. He made it to join us, and Dr. Wren, who have dedicated so much time to this series. If you have attended this week's webinars, you've probably seen them, but we're thrilled to have them back again today. Dr. Adunka is the director of the Division of Otology, Neurotology, and Cranial-Based Surgery at the OSU Wexner Medical Center. And Dr. Wren is an otolaryngologist specializing in otology, neurotology, and skull-based surgery. Dr. Bjelac and Dr. Wenger, welcome to both of you. I'm going to stop sharing my screen and let you introduce yourselves as well.
Hello, everyone. My name is Matt Bjelac. I'm a physical therapist with Ohio State and the outpatient rehab vestibular team lead for OSU. I've been a physical therapist for 8 years, and I have my specialization in neurologic physical therapy. I'm excited to talk to you today.
Hi, everyone. My name is Greg Wenger. I'm a physical therapist, also Ohio State, working on the vestibular team with Matt. And my background is in orthopedics. The past 15 years or so, I've been focusing really on vestibular rehab. I'm definitely excited to be here with you tonight. I'm going to go ahead and share my screen and start the presentation. All right, can you see that all right?
Yes, it looks great.
I do want to say thanks initially to the Acoustic Neuroma Association for hosting us this week, and Melissa for being with us each night. It's been a great week. If you haven't caught the earlier ones, make sure you have a chance to take a look at those. And thanks in particular to each of you for being out there and joining us. We're excited about your interest, and we're here ultimately while we're here. So we hope you learned something tonight. Tonight we'll be discussing how an acoustic neuroma might cause imbalance or dizziness, and how a physical therapist who specializes in vestibular rehab can help assess you and design a plan to help improve your balance and function. We'll start by answering, why does an acoustic neuroma impact your balance? And to answer that, let's start by discussing what occurs with normal vestibular functioning. You have two vestibular apparatuses, one in each ear. They're mirror images of each other. They're considered redundant. In other words, they send the same information to the brain through the vestibular nerve. They function in what's called a push-pull relationship, wherein they send equal and opposite information. For example, if you turn your head to the right ear increases its firing rate, and the left ear decreases its firing rate at the same amount at the same time. And that equal and opposite response tells your brain in what direction you're turning. In the ideal scenario, the information matches and it's symmetrical. When someone has an acoustic neuroma, however, less accurate information is sent from that ear to the brain. We term this a hypofunction, meaning a reduction in function of that ear, at least a slower processing of the information because it doesn't match. Your brain needs to figure out which ear is sending the correct information, and to do so to look to other systems of balance. So we're going to look to what you're seeing visually, feedback from your muscles and joints, and compare that to the information from your ears to determine what's accurate. Your brain can do that, but it takes a little longer. So your balance response, your visual orientation might be slowed down or negatively impacted. So what implications does this have on your balance? We might use the word dizziness, which has a very broad definition. The most common form of dizziness experienced by those who have an acoustic neuroma is imbalance or possibly reduced gaze stability, which we call oscillopsia. You may have heard the term oscillopsia. That occurs when your eyes aren't remaining fixated on something when you move your head. You might have the impression that things are moving up and down as you're walking, or if you turn your head, it takes a moment for things to catch up. You can also have mental fogginess because the brain's slower to process that information or might get overstimulated. Vertigo, which is a sense of movement, which is not occurring, most commonly spinning, does not typically occur for those with an acoustic neuroma except right after surgery. So you may notice imbalance or mental fogginess during the day if you're challenging your balance systems. For example, having some external force impact you, like as the picture shows there, someone swinging a child while they're walking, or more commonly if you're getting bumped by somebody in a crowd, or perhaps walking on uneven ground. You might notice some imbalance if you're walking and looking around or trying to talk to somebody while walking. And in a grocery store, as depicted there, is a very common place to have an experience of dizziness, some overstimulation, imbalance. There's a lot going on visually in a grocery store as you're moving and people are moving around you. You're scanning things on the shelves, and that can be overstimulating if your ears aren't sending the same information. So why is this different than an acute vestibular event? Acute vestibular event is a sudden change in feedback from one ear, and that can be caused by a variety of things. A viral infection is most common. Other examples would be a stroke or Meniere's disease. The point with all of those is that there's a moment in time where you get less information, significantly less from that ear, and substantial change. Typically in that experience, vertigo occurs, and then that's followed by some oscillopsia, some of that slowed or visual lag that we're describing. So that can occur after surgery for an acoustic neuroma, generally within the first couple of days, but it typically doesn't occur during the natural progression of the tumor. Even though that tumor is resulting in reduced function from your ear, it's not enough that it's going to cause that acute vestibular event. And that is because of a phenomenon known as neuroplasticity. Your brain's constantly processing a large amount of information from your eyes, ears, muscles and joints, and when you're walking and moving around, just to know where you are in space. When there's a change in that information that it typically receives, it can adjust how it processes. It's very well designed in order to process that information and determine what is the most accurate of all of that. So in our scenario, that is having an acoustic neuroma, the brain will begin to receive slightly inaccurate information from the affected ear because of the impairment of that vestibular nerve. And that's called a hypofunction, that reduced function, reduced information from that ear. However, that tumor is slow growing typically, and each stage, the brain has some time to make adjustments through what we call neuroplasticity. Your body essentially heals itself. Neuroplasticity can occur in a variety of ways. In a case of an acoustic neuroma, where it's triggered by misinformation from the vestibular system, we call the neuroplastic processes adaptation and compensation. So try this with me for a moment. Hold your thumb out in front of you and quickly look at it while you quickly turn your head. While you're doing that, your thumb should appear to move still. You can look at any stationary object. For that to happen, your eyes have to move in their sockets. If you turn your head, your eyes will move the same speed, opposite direction of your head to stay fixated on something. And that's caused by a reflex called the VOR. And that'll happen if your ears are sending your brain the same information at the same time. If they're not, if there is a hypofunction, there might be a visual lag, which we call oscillopsia. So if that does occur, your brain can adjust over time and reweight the information from your ears. So your eyes now move appropriately and your thumb or that object you're looking at no longer seems to move. We call that process adaptation. And that can occur by actively moving and doing things while you're fixating on something, but can really get sped up by doing some specialized exercises that Matt will cover here in a bit. So adaptation is part of a larger concept known as vestibular compensation. Vestibular compensation involves the brain reweighting information from your ears and from your other systems of balance, what you're seeing in particular, and feedback from your muscles and joints. So a sign of a compensated vestibular system, because that's the ultimate goal with physical therapy and in general, is that you're able to move and remain and not have oscillopsia, or keep your eyes fixated on certain objects and not be imbalanced. So if you're having some imbalance or some oscillopsia, then you may be a candidate for vestibular rehab, so we can promote that compensation from occurring. So what should be done now, or where should you start ultimately? At this stage, it's recommended that you're assessed at a center, which includes several specialists who have experience in collaborating to determine the best plan for you. If you joined us earlier in the week, you may have heard from many of these specialists already. On Monday in particular, they were talking about that multidisciplinary care, and it was an excellent presentation if you have a chance to see it. But ideally, you want a team with experience and awareness of recommendations from the research to help educate you and guide you in your journey. So generally, 3 paths to consider by those specialists will be monitoring, performing radiation, or undergoing surgery. And that medical team will help guide you in that decision. From a vestibular rehab perspective, though, each of those could have different implications on your balance. Neither monitoring nor radiation involve an immediate change in the size of the tumor. Monitoring might involve continued growth over time. As Dr. Palmer mentioned earlier in the week, that growth is generally not linear. So in other words, it may grow at different rates at different times or plateau. If it's changing, it's sending varying information to your brain. Your brain compensates the best with a static change. So essentially, if your brain's receiving inaccurate information, but it's the same inaccurate information all the time, your brain can adjust to that. But if that information changes, if at one time it's sending not accurate information when you're turning at a certain speed, and then there's more pressure on that nerve, and now it's sending different inaccurate information, that's harder for your brain to adjust. Your brain has to continue to attempt to adapt and compensate. So therefore, if you're monitoring, you might have some fluctuations in your balance. It doesn't necessarily correlate with the tumor size, as Drs. Adunka and Wren mentioned on Tuesday, but a PT with a background in vestibular rehab can help assess your balance and determine what systems are causing that imbalance and address them. So for radiation, as Dr. Palmer mentioned, the goal really is to create to halt the growth of the tumor, to create more or less a static state, which can limit the fluctuations in balance feedback. But still, there are some processes that can occur to change that feedback. And so it still might be beneficial to participate in vestibular rehab. Ultimately, your symptom experience is a good indicator of whether vestibular rehab might be a good option for you. In other words, if you're experiencing imbalance or oscillopsia or dizziness, that'd be a good time to consider vestibular rehab. The surgery, on the other hand, is a different scenario. This causes a substantial change in feedback, namely the absence of information from that treated ear. So it's a very rapid change, and that's an example of an acute vestibular event that we discussed earlier. That typically leads to true vertigo or spinning immediately after surgery. However, that generally resolves within a few days through that initial vestibular compensation. But after that, you still may have, and likely to have, some imbalance and oscillopsia, at least for a period of time. So the positive side to this, though, is that a static situation has been created. The brain will no longer get fluctuating information from the affected ear. It's receiving no information and can rely then on your other ear and your other systems of balance. It just needs to adjust to that new state. And it can adjust through adaptation and compensation, as we mentioned. In order for it to happen, you need to move. That's really the challenge to you, really through your journey of having an acoustic neuroma, and especially right after surgery. is you need to commit to be active and challenge your balance. Vestibular rehab can help guide you through that. So you kind of understand what are some good activities to take on and how often and how much and that sort of thing. And the most effective way to improve gaze stability, to reduce that oscillopsia or eliminate it, would be through some specialized exercises. So that's in addition to just being more active. So speaking of being more active, fun fact is that research has shown that preoperative physical activity status is a positive prognostic indicator for short-term balance compensation after surgical removal of the tumor. In other words, if you're active, you'll have better outcomes. And this activity ideally would be fairly vigorous. So not just kind of leisurely walking, but should involve something that's exertional, involves challenges to your balance. The good news is this is something you can control. You can make the choice to be active. Many of you might just naturally be active, but even those that aren't, you can choose to become active. Develop a plan for exercising, commit to stick to it. A PT can help design a plan tailored to your abilities and your goals. So you might wonder, what would you expect from vestibular rehab if you were to come to see a therapist like Matt and I? So vestibular rehab first involves getting to know you and your goals, taking some baseline measurements, designing an exercise or activity program then to meet your needs. This could occur at any point in your journey if you're dizzy or having balance difficulties. So at any point, as you're kind of working through the acoustic neuroma or certainly after surgery, Matt will discuss a little more what that entails in a moment. If you are planning to undergo surgery, you might participate in what we call prehabilitation. In prehab, we can help discuss and prepare you for what to expect from a balance perspective after surgery and get some baseline measurements. And then what you can do to get kind of a jump start on the rehab after. So there are three systems of balance: your vestibular system, feedback from your inner ears, what you're seeing visually, and feedback from your muscles and joints, what we call proprioception or somatosensory feedback. If you're getting misinformation from any of those systems, in the case of the acoustic neuroma, the vestibular system, then that will cause some imbalance, or that can cause imbalance or dizziness. We can help through vestibular rehab to your brain to reweight the information to address the potential areas of weakness. So at vestibular rehab, we start by performing tests of each system. We'll do some general balance tests, and then we're trying to test each of those three systems. So from a vestibular perspective, there's specialized equipment that can help identify the presence of a hypofunction and quantify the amount of hypofunction. So it's helpful to get some numbers to establish a baseline function. And more importantly, depending on those numbers, we can create a customized exercise routine for you. And then we'll attempt to identify any areas of muscular weakness or difficulty with your eye movement control, which could be negatively impacting your balance, separate from the acoustic neuroma, but playing a role. And we can determine if there might be some anxiety or avoidance of activities due to fear of imbalance or falling. So that's not unusual, and that's helpful to identify so we can come up with a plan to address it. So here's a few take-home points from what I've spoken with so far. Really kind of a summary. Two big points are this. First one, how does your brain respond to impaired balance information? Your brain can adjust to that difference in balance information coming from your ears, in this case, vestibular system. It does that by reweighting and prioritizing the more accurate information from both your unaffected ear and from your eyes and muscles and joints. So it can do that. The good news is, because what can we do about it? The good news is you can do something about it. You can certainly choose to be active and challenge yourself physically. Now Matt's going to explain a little more what you can expect in vestibular rehab, and I'll stop sharing my screen here.
We good now? Sorry, still muted. So I'm going to run through really quick, just a very broad case review. And again, the path is not linear for every person, and everyone has to make an informed decision that fits their life needs, right? And they have to use their doctor and their other medical resources and that entire team-based approach to really, feel like they're doing the right thing for themselves. So say, for example, we have an individual who has acute onset hearing loss in the right ear. They're sent to an ENT. Following a plethora of additional tests, the physician identifies an acoustic neuroma in the right side, and there's a decision to move forward with surgical resection after consult. So after surgery, what can one expect from a balance impairment, as this can be kind of the most pronounced balance effect that can happen in this situation. So usually we really recommend that therapy is consulted as quickly as possible after surgery, as there is a very big time window that we want to get the best outcome. In this physical therapy, you'll have, again, a balance assessment. For this particular person we're discussing, they cannot stand with their eyes closed, they're drifting when they're walking, they're using a wheeled walker after they've been discharged from the hospital from their surgery, and they have a significant difficulty with walking and turning their head. In regards to vestibular function, there is a significant abnormal VOR. So Greg went over what VOR actually is in terms of that ability of our eyes to fixate on a target, and we can test that via specific computerized testing. And you observe nystagmus, which is contributing to why you would feel, or that person feels like they're constantly dizzy after surgery still. Overall, their eye function is normal. Their neck is stiff and weak. They just had surgery, and they've been guarding and holding their head for some time. And there's some decreased coordination and proprioception, as well as some just different functional weakness and endurance issues that exist. And then usually we recommend in our care that some type of patient-reported outcome measure that tracks objectively your subjective perceived improvement in regards to symptoms is helpful. So in this case, therapy is initiated within 2 weeks from the surgery date. We schedule PT for 1 time a week for 6 weeks after surgery. An initial home program is given after that first evaluation and baseline measures are found regarding balance and VOR function. So I know Greg kind of started to introduce this, but the primary foundation for all of the VOR or all of the balance training is going to be centered on 2 exercises called VOR times 1 and VOR times 2. You'll hear those words used interchangeably with gaze stabilization exercises, as well as adaptation exercises. There's a lot of specific lingo that comes along with this, and a lot of it crosses over into different topics. So in these exercises, and again, I want you to be safe, so make sure you're sitting right now, as I don't know all of you, but you would put your thumb out in front of you and you would rapidly turn your head while you keep the target in focus, moving your head about 20 to 30 degrees. That would be our VOR times 1 exercise. Now in your therapy, your therapist is going to be able to change the speed, the range of motion, how frequently you're doing it. All those variables are good to be controlled so that you can have the ideal outcome. And the second exercise is called VOR times 2. And that is where the target is moving past where our vision fixates and you are keeping your eyes on it. That would be a progression from the first exercise. So in this picture, you can see that the first picture is someone doing VOR times 1. Her eyes are staying fixed on the target. Ideally, the target would be on the other side. I just did that for your visual purposes. And then the second picture is VOR times 2. She's moving her head past and moving the object past the opposite way, but her eyes stay fixed. The third picture would be what would see happen a lot in the acute stages, or of someone who has a high degree of vestibular impairment, where the eyes want to slip away from the target. And so this can help describe that feeling that people have where they want to keep falling towards the side that they turn their head because their eyes are not eliciting that reflex back from the inner ear function. One specific way we really use is computerized training. So it's a very incremental way to track and target range of motion and speed and size of vision or size of font that you can read. It's really proven to be useful to kind of gauge progress as we track outcomes. Some of the other components that you would see in vestibular rehab would be the concept of habituation. So this goes back to that idea of neuroplasticity, that the brain is this plastic entity that can change and alter its response and understanding of things. And we do that through repeated exposure or stimulus of specific movements. So your therapist would work to identify the movements that provoke the symptoms the most for you or more functionally intolerable. And you would practice those movements repeatedly, incrementally throughout the day until your brain accustomed to them or became accustomed to them. The other would be substitution exercises. So you saw that nice little triangle picture that Greg had where the different balance systems are working. If there is loss in one balance system, the other systems, we want to make sure that they are also firing on all cylinders, as well as postural stability in terms of the integration of the way that we move our head and our body, and we avoid compensation movements that would actually reduce balance function. So pictures here would be examples of different exercises that you may try in physical therapy or vestibular rehab, things such as standing on unstable surfaces, moving your head with your eyes closed, bouncing a ball, standing on one leg, walking heel to toe, anything that would really challenge your integration of those multiple systems. And then things that focus on strength and posture, right? So the ability of us to know where we are in space, to have strong muscles that support our stability of our body, as well as good posture and neck control. So in the wrap up of this quick case, this patient, he only ended up performing 5 weeks of therapy because he did his home exercises. I'll talk about that, the value about that in a little bit. And then there was improvements in the gaze stabilization via the computerized testing. So this is one of the methods that we use to track the actual capacity of the eyes to remain fixed on different sizes of font and targets. And then we usually use a plethora of outcome measures, dynamic balance measures, static balance measures, as well as balance confidence and self-reported questionnaires to show the patient and ourselves and the payers for insurance the progress that we make in therapy. So why does all this work so well? And when I make a decision, I want it to be informed by evidence myself, and that's how our team operates. And so we really value the use of some of really, really strong evidence that exists for the rehabilitation of someone with a peripheral hypofunction. The Academy of Neuro-PT has recently updated a 2016 clinical practice guideline, which a clinical practice guideline usually stands as one of the most recommended and higher levels of evidence that exists, as it's a very complex synthesis of all the research that exists in a topic area. Some of the main findings from this evidence that really drive the care that you will receive if you would choose to have surgery or to not have surgery is that vestibular rehabilitation is effective. So there is level 1, the best evidence that exists out there, that supervised vestibular rehab is superior to getting outcomes for you in terms of balance as well as return to normal function. So it really helps to promote adherence to your home exercises rather than just generic home exercise programs that are provided but never really progressed. Another thing that it talks about, and I saw some of these questions in the chat, and I hope this answers, is that things such as age and gender do not matter for the outcome, right? What does matter is comorbidities. So regardless of age or your background or demographic, it's more the health status of you that can really affect the outcome. In terms of timing, early intervention does improve the outcomes. So when we talk about improving outcomes, right, you can see that it will get you better faster, right? If you start to treat a problem sooner, you're not going to compensate in negative ways, and you're going to learn to recover faster than someone who does not start and then has to overcome other barriers along the way. The good thing about this literature is that we still really do a good job in balance therapy on chronic symptoms, right? We just know that it needs to take longer, and we have to increase the dosage of how much someone does an exercise to get the outcome that we want. So all is not lost if something happens and the intervention doesn't happen as soon as possible, but that's what we highly recommend. Some other things to know is that there is level 1 evidence that physical therapy and vestibular rehabilitation cannot harm the process of doing this, right? Our job is actually to provoke the symptoms of imbalance and dizziness. That's what we do best, but we do it best by helping you recover those symptoms and by teaching your brain that those symptoms can actually be improved. And so with this, there was significant improvement in disability and anxiety scores in the patients of the studies that they looked at. And one other thing to note in this is that if you are seeking care and you're finding that the therapist is only recommending eye movement exercises or pure compensation, it's not the ideal evidence-based care that you deserve, and that we really need to provoke head movement and have highly dynamic exercises that focus on VOR training and balance exercises to really facilitate the best outcome. So lastly, the best outcome centers on intensity, right? And it centers on the amount of time that you spend practicing balance and the amount of time that you spend practicing VOR exercises. So there is level 2 evidence that exists for the utilization of gaze stabilization exercises for unilateral hypofunction. And in the acute phase of things, this is why it gets better faster, is that it needs to be done less. So about 12 minutes a day for 4 to 6 weeks, these exercises are instructed, and then they're progressed in different conditions. In the chronic cases, it's about 3 to 5 times a day for 20 minutes a day total for 4 to 6 weeks. Now, your therapist, and this is why supervision is key, is that they're not going to want you to shake your head for 20 straight minutes, because we would all have a headache if we did that. So they're going to teach you how to break it up throughout the day and how to implement it into the day, your daily schedule that works for you. Another thing to take note as a balance, as a second concept, is that some of the literature is actually saying that we need an additional 20 minutes of balance exercise that's targeted to some of those balance exercises that I had in the pictures of walking heel to toe, standing with your feet together, standing on different surfaces, to really get a therapeutic effect. So these are not combined in the same category. They really need to be separated, and then they really need to be produced in these high intensity but shorter duration intervals to get a great outcome. So overall, I just wanted to finalize with like a wrap up of our vestibular team here at Ohio State. We have 5 separate outpatient locations if you are from the Central Ohio area. We have a very robust team with programming with different clinicians of different skill sets across all of Columbus and Central Ohio, as well as team members across the entire acute vestibular acute hospital team, as well as other locations throughout the medical center. But the thing I want to recommend most is that if you seek care from a physical therapist, we really want you to find a specialist, right? No matter where you're from, there are providers all over the country that specialize and treat vestibular conditions that really, value the use of evidence and that really can support the care that you deserve. Thank you.
Yeah, this was awesome, guys. Thank you.
Yeah, that was fantastic. Thank you both. Really appreciate it. We do have quite a few questions.
Let's
Dr.
get right
Adunka,
to
feel
them.
free to jump right in there.
Most questions I saw are for our friends here. So
I know. So one of the first questions that came in really, and you did discuss a little bit about radiation versus surgery and balance issues associated with that. Do you see more balance issues after radiation than surgery, or is it, does the type of treatment not really matter?
I would say right after surgery, there's a significant change, just because, as we discussed earlier, that involves this sudden change in feedback to your ears. And but on the positive side, that does create the static situation, so your brain can adjust. So long term, generally, that's a good functional outcome. And I know Dr. Adunka was commenting on that earlier in the week, so I think that he's in agreement with that. After radiation, if you haven't had a chance to see Monday's presentation, Dr. Palmer was commenting that, again, the goal is to kind of sort of freeze that tumor, but you still may have some fluctuations in growth. Radiation itself can have some effect on some of the surrounding tissues, and there may even be what they call it, I believe, a pseudo tumor.
Pseudoprogression, right?
Pseudoprogression.
Yeah.
So you can still have some changes in size, not necessarily from cell growth. But the point is, all of that creates this fluctuating information from your ear, which can lead to kind of long-term or changes in your balance. So it's hard to predict, quite honestly. But for the most part, long-term after surgery would be better balance scenario.
Okay.
Thoughts there, Matt, or anyone else?
No, I just would say I think radiation from a function perspective is more a little unpredictable, just because the effect isn't instantaneous like a resection is. That doesn't mean it's bad. It just means that you just can't quite put your finger on what's going to exactly happen. So yeah.
Is having balance issues prior to treatment any indicator of what will happen afterward?
Yeah, so maybe let me inject here. So yeah, I think if someone's dizzy before management, right, we would be hesitant to recommend radiation. It's typically worse, right? If someone's not dizzy and they have radiation, oftentimes after about 6 to 12 months, we do see some fogginess and dizzy, sometimes true vertigo kind of symptoms. So it's really unpredictable, but we do recommend physical therapy that usually takes care of it. Sometimes, Dr. Wren and I will have to do gentamicin injections or other things. There's some other, I think it's just really important to recognize there's some other options, if really we're running into the problem that all these not operative things, have not really helped dramatically. But, the bottom line is if you have balance symptoms before, they're probably not going to get better with radiation.
Okay.
Yeah, I would agree. I think that transitions naturally into one of the questions from earlier about whether vestibular rehab was recommended before surgery, preoperatively for the monitoring phase if symptoms are minimal. I think, you guys' presentation addressed this also. I think it's important to first establish a relationship with the physical therapy team. So that will be useful preoperatively. And also they might identify, deficits that you may not realize you had, and also just to establish a baseline so that, there's some objective measures for the patient to, sort of achieve, like, this is how I am before. And, if everything goes well, this is hopefully what I will be afterwards, so that you can have some basis for comparison. Even if the problems are minimal, I think it's worth seeing them. You may not have to do, 6 weeks of treatment, but at least seeing them and establishing that care would be important.
Okay.
Yeah, I would second that like we really, we want to see people who have a true functional need, right? Like if there is a safety concern or if there is a, significant balance concern, that still is true rehab, right? It's the coined term prehabilitation that, I think that what Dr. Wren said, like we want to establish relationship and kind of outcomes, and it might be very short and brief, but it just helps with the continuum, right, of care, especially because there's a lot of appointments and a lot of providers, right? And you're trying to provide like good integrity of that outcome. So,
yeah.
Does that lead also kind of into it on the other hand, on the other end of the spectrum? What about people who had treatment 10, 15 years ago or whatever, but are still experiencing vestibular distress? Is there value in therapy at that point as well?
I would say yes.
I would agree. I think that really pulls into this idea of this multidisciplinary care, because if you're still having issues that far down the road, what might be contributing to it. And so having certainly a good medical workup by a neurologist or other specialists to determine what's the status of the acoustic neuroma, or possibly even if it was resected, and then have some changes on MRI, like one of these other questions had mentioned. But from a PT perspective, in any of these scenarios, there still could be some fluctuations. Even you could argue in your resected ear should give you similar, non-existent, I guess, feedback, but your non-operative ear, there's other things that can influence that, including effects of aging and I won't go into detail, maybe other things that could affect that. So those can all play a role. And so if you're still experiencing imbalance that far out, absolutely, there's progress to be made. And I think that would certainly be a good time, as Matt was saying, if symptomatically you're having trouble, to come on into vestibular rehab.
Okay. And there's a couple questions. We have this on the Facebook page as well about how long you should continue vestibular or the home exercises, after you complete vestibular rehab. Is that something that should just be ongoing?
That's always a tough question, and there's not like a really true answer for it. In the literature, like in the evidence that exists, I personally will recommend like a slight taper, right? And that like if they're doing well and they feel like, and they're testing normal, mostly in their functional capacity, that like they can taper it a little bit. But that if they would continue to then present with some type of instability or something, that they know what they need to do to try to work on it. A lot of people who really invest, they don't find them harmful, right? They find that they're kind of like their saving grace of feeling more normal again after such a, big change. And that I think that they will kind of self-regulate that themselves. I know that's not like a perfect answer for everyone, but I think it depends.
There can be some sort of decompensation, as they call it, over time. If you're looking at specifically gaze stability, doing those exercises where you're turning your head, once you're testing normal and it's not symptomatic, then there is a recommendation in place that you could stop doing it, but sort of do a self-assessment once a month. And if there is some visual lag occurring, then start them back up again. So it does depend on many factors, but one that you can control is how active you are. And if you're doing movements and engaging activities where you are involves a lot of head movement and a lot of balance challenging scenarios, then you would be less likely to decompensate than if you were spending a lot of time hanging out on the couch or on a computer.
Sure. Okay. You mentioned the gentamicin injections. Can you explain what those do?
Sure. So gentamicin is an antibiotic, actually, but we're not using it to treat an infection. So it's a really old antibiotic, and it works great. And what people have found over the years is that it is actually toxic to the hair cells, which are these cells in the inner ear that helps us hear and helps us maintain our balance. So when we say we offer gentamicin, we're not offering it as a pill that you take, but we're actually doing a very targeted treatment by making a tiny hole in the eardrum and putting gentamicin in the middle ear. And the thinking is that some of that medicine will make its way into the inner ear and affect the balance organ of the inner ear, or the vestibule. And what the end result is often is if that balance nerve, or if the part of the inner ear that maintains balance is damaged, in this case from an acoustic neuroma, then if we actually ablate or kill off or damage intentionally the hair cells in there, that may not be working as well anyway. So instead of giving the brain a faulty input, we're getting rid of that input completely and allowing the brain to actually compensate and kind of regain their balance function better. The caveat is that sometimes gentamicin can damage hearing at the dose at higher doses. So it's a discussion. We have to look at what your hearing is, what your other ear is, and how your balance function is, and to make that determination. So that's something we should discuss with your otolaryngologist.
Okay.
Melissa, there's one question about the potential benefits of hearing aids for balance, right? If I may start with that, and I would love to hear everyone else's input on it too. But so what I usually counsel patients on that, hearing aids, there is a benefit to balance, right? What we see in older adults who have age-related hearing loss, right? There is a benefit. I'm not entirely certain about specific literature on hearing aids for folks who have acoustic tumors, but I can only imagine that there may be some benefit to it. So I'm not aware of any specific piece of literature that points to a particular balance benefit of hearing aids. But again, for age-related hearing loss, we do that's part of the counseling in that. I don't know, Yen or.
Yeah, I agree. I don't know if there's a direct link of how putting hearing aids would help balance specifically, but one reason I can think of makes sense to me, and is that if you're having trouble hearing, especially in daily situations, your brain gets tired. You're always trying to hear other people. People describe brain fog. The tinnitus may be bothersome, and sometimes if your balance is off, or if you have some issues with that, it also takes a lot of brain power to watch where you're going. Sometimes you have to hold on if you turn too quickly. So you only have so much sort of energy dedicated to that. So if there is some way to alleviate pressure, I guess, or stress in one way, that may help with their balance indirectly. So and also hearing aids has a lot of has been shown, especially in patients with age-related hearing loss, that independently can affect overall sort of brain health and the development of dementia sort of independently. So I think, it's sort of what we call it a silent disease, right? So people rarely complain that their hearing is gone. It's often their family, or they find themselves very isolated. All of those are, potential things that hearing aids can be tremendously helpful.
And when we talked earlier about the 3 systems of balance, so eyes, ears, and feedback from muscles and joints, your neck is very important. You think about if you're moving your head around, feedback from your neck and your eyes and ears should all be the same. I've seen folks who, if there's a significant hearing loss, they'll turn their better hearing ear towards me when I'm speaking, and they end up doing that a fair amount during the day, and that can have a negative impact on their neck. You can get now asymmetry from the sides of your neck, and that can trigger dizziness, some balance difficulty, cervicogenic dizziness. So there could be kind of a secondary effect of that.
We often hear from patients that, not often, but on occasion, we hear from patients who have tried vestibular therapy and they don't see the results that they would like to. They are not able to get back that balance. And there's a question on the Facebook page with a patient who had surgery in January, has been going to physical therapy 3 times a week since the end of January with really no improvement. So how do you counsel patients like that? Do they just continue? How does that work?
Usually not just continue. I mean, if, it's supported in the evidence as well, and that hypofunction guideline, that if you're not achieving goals and you're not achieving outcomes and you're doing the interventions the way that you should, it really does take speed and dosage, right, to really drive input and also to compensate. There's also, everyone has different comorbidities that also could be barriers to, continued like progress and improvement. So I think it involves kind of counseling of the cost benefit of what you're getting out of the situation. So if you're not seeing progress, then it might not be the intervention, or the right place. I don't know if I want to say that, but like for you.
And we usually, what that would trigger is usually a call from you guys to us, right? Or some kind of message that, hey, this patient has an inadequate response to physical therapy. Maybe there's something medical going on, right? So then we would sort of become active again to investigate some more. But it's something we sometimes do here, and it's rare, but it's certainly something that, it does happen, unfortunately.
It is rare.
I
was just going to say, it's really rare to have someone who doesn't improve in anything.
Right.
And usually that involves, are they practicing the level that they should? Because again, it's that neuroplasticity and that effect. And even just to improve endurance or posture, like Greg had talked about, like there are tangible things that we can change. So sorry, Greg.
I would just go say, it would be helpful to explore why they're not progressing and decide either perhaps they're not doing the exercises enough, or maybe we haven't really instructed them in the best exercise, or maybe there are some secondary factors, or there's some kind of fear avoidance that's lurking under there that's not clear, not obvious. And through discussion, people start realizing, I have been avoiding a lot of things. It's not unusual that we start to have some imbalance and we stop doing that, and we don't even realize that we've reduced our function. And so taking some time to point that out. And if it does seem like someone's really on task with what they're doing, they're compliant, and we're observing them in the clinic and just not making the progress, then certainly there could be something else going on medically, as Dr. Adunka is saying.
I would say with an untreated acoustic tumor, right, where we just go for balance for older individuals, et cetera, I would be concerned that the tumor is actively taking away balance, right? Or so I would say that every time the brain has a consistent situation in terms of the periphery, in terms of the input from the balance system, I would say that you guys will have a good substrate to do your therapy. However, if there's some changes because of the acoustic tumor, right, or because previous radiation, for example, those things can change over time, then it becomes more difficult, I would say. Right?
This, I would say, leads a little bit into this question of somebody right here for older surgical patients, greater than 55, despite being active pre-op, please comment on, are there predictors or risk factors for ongoing dizziness post-op? And also a secondary question is anticipate the time frame for recovery. And so those predictors for ongoing dizziness would be some of these comorbidities that we're mentioning, some problems with your other systems of balance already. So if there is significant weakness in some core postural muscles in particular, or tightness, lack of activity, which you already said is not the case necessarily with you. If there's any sensory deficits, peripheral neuropathy, anything along those lines, impacting the somatosensory or proprioceptive feedback, that could slow progress potentially. And anxiety or even hypervigilance, like for some people, being type A is helpful in many aspects of life, that we can be driven and focused. And yet, from a dizzy perspective, that can sometimes work against us because our brain's focusing too hard on the dizziness, and it needs to sort of be turned towards function, towards what we're doing. So as far as the time frame goes, that is somewhat variable. And you put it there greater than 6 to 12 months. I think having some recovery or improvements, I should say, in function up to a year would not be unusual. The majority of them should happen in a shorter time frame, in 6 weeks to 12 months. I'm sorry, 6 weeks to 3 months.
I was going to add one thing, and that's what time frame for recovery versus time frame for therapy sometimes aren't linear together, and that you might do 6 to 12 weeks of targeted therapy. You might be doing really well. You might go back to work. You might be exercising, but you still just might not feel exactly like you did, right? Or as good as you want. And that doesn't mean that you're not going to recover more. It just means that you need more time to continue to kind of compensate and to, drive that neuroplasticity via the exercises. And I think that that's a hard thing to maybe kind of comprehend a little bit at times, because you want to just that timestamp of the end date. But that's where I don't tell my patients hey, I'm done, you're done, right? No, you can keep going, keep practicing, and you can keep recovering over time. And that's why follow-up with the doctors is so great, because they can then kind of keep that line of communication going, anywhere from a year or 2 years after.
And we talk about sort of embracing the dizziness. If something causes imbalance or dizziness, then it's helpful to switch the way you approach that mentally and realize that's a good thing. That's going to help me, as opposed to being afraid of that and avoiding it. So it's like if we're working out and we get a muscle burn, then we associate that with a good thing. We're going to get bigger, faster, stronger, or more healthy. Same thing, we're doing something and it creates a little dizziness or imbalance. Realize, that's good. I'm challenging my brain right there. That's something I need to kind of do and continue with.
Maybe, Melissa, we can do one comment here. I saw Moretta, I think, put in the chat here. Address is really 3PD, right? So,
okay, I don't know what that is. So I was hoping
it's a weird acronym, and it's something that's pretty much come up relatively recently. What it really says is persistent postural perceptive dizziness, right? And it's this what I would call a bucket, right, of several things that we don't fully understand. It's really folks who have this fog, right? There's oftentimes a migraine history, and I think going back to the question we just answered, right, about predictive factors, right? So we're looking at if folks have a history of migraines, for example, right? Migraines can cause this migraine-related vertigo. Then it makes Greg and Matt's job a little harder, right? Because you have these daily fluctuations, and 3PDs is similar, right? Obviously, the vast majority of folks who have 3PD don't have acoustic tumors, but if you have 3PD and an acoustic tumor, right, we would certainly feel like that would be somewhat of a barrier, right? Would you say, Bien? I mean, would you agree with that?
Yeah, I mean, it's a relatively new diagnosis, I would say. Sometimes, we kind of go through our bucket list of the more common diagnoses, and people often describe they have this general feeling of imbalance, not really vertigo, but they just feel like they're not standing on a balanced, firm footing. And motion really is often a really bad trigger. So if they're driving, things are changing a lot around them, or things are moving, that can trigger it. We work with our again, it's a team approach, even though it's not acoustic tumors, but neurology sometimes are useful, and they can sort of figure out, is there a migraine component? Some of the medications that have been shown to be effective are sometimes antidepressants, and we almost always, for my practice, I work with Matt, and I, kind of give them the option and strongly encourage them to go through vestibular physical therapy, just to help them identify what the triggers are. And a lot of these patients have a significant level of anxiety. And sometimes those two can be linked in a way that's counterproductive. So they get more anxious, they're afraid to move in a certain way, and things just kind of, spiral out of control. So, working with physical therapy to figure out what are the good ways to compensate is often beneficial, but it can be a very hard diagnosis to treat.
It maybe one question I have for you guys, because it comes up to us all the time, is about driving, right? So a lot of our folks ask us, hey, when can I go back driving again? And frankly, when folks, when they're post-op or even with radiation, I often don't have a good answer, right? I usually defer to physical therapy, but maybe you can walk us through your process there.
Well, there's a question on Facebook also about, a little bit more intense exercise, like running, jumping, weightlifting, that kind of stuff.
Yeah.
So how do you advise patients there as well?
Great.
You want me to take the driving and you take the other, Greg?
Sure.
Driving is tricky because in terms of removal of driving privileges from a doctor, which usually does not happen with this, correct? It's more kind of when you're ready to go back from the surgeon.
Typically,
It is more of a patient kind of comfort level, right? Physical therapy does not release people for driving. In the state of Ohio, there is occupational therapists that will focus on driving rehabilitation, and it's a very structured, like, specific thing. And that does not mean that everyone who has this has to go through it. That they will provide recommendations to doctors who have had driving, like, medically suspended, obviously not from a license suspension, but like from just like, it's not safe for you to drive right now. In terms of just advocating and encouraging patients, I think and this is just advice, right? So this is not a telltale. I usually try to say, like, you want to feel like you are secure, right? You want to feel at least like walking around and moving around, right? That if you turn your head, you're secure. And if you feel like that it's just a gradual approach, right? To try to, like, get yourself in the car, check your mirrors, right? Look around, drive around the block, right? And this, again, is just advice, because you have a valid license, you can go drive. And so when it comes to higher level stuff, and if there still is really an anxiety component to it and a very, like, vigilant feeling about it, then it needs to be addressed from more the either testing out with a specific driving rehab program or the psychological treatment of it through, like, a rehabilitation psychology, if it's more of feeling like a anxious barrier or a phobia almost, which is normal. Sometimes people experience that. So there are avenues to address the issue. Most people that I've worked with, on an anecdotal note, they say, I'm ready to drive. So they get back in the car and they drive when they're feeling better. Right. I think that they just don't know that exact time point, and I don't think that there is.
Yeah, what I say typically is if you can do the shoulder look, you can do it, right? But just tell me when you're on the road, so I'm not.
No, they're going to be good. We have confidence. If their rehab is good, they'll be good, right? Like,
yeah, and when you think about it, with an acoustic neuroma, it creates this hypofunction, and whether it's pre-surgery, certainly post-op would be probably more time when someone would have concern about returning, but that your brain will compensate for that as long as you're active and you move. And that's where some equipment can be helpful, not just with driving, but some of these other activities that were mentioned that are a little more exertional, running, hopping, jumping, maybe some plyometrics, burpees, and that sort of thing that involve a quick change in head position. Those can all be dizzy provoking, or certainly that shoulder check, as Dr. Adunka is saying, or following objects as you're driving down the road. All of those can be negatively impacted if your brain is not compensated for this change of information. And so, so doing exercises will help. Having that some specialized equipment to measure that can be helpful. We have a computerized visual acuity system, and that can help quantify the amount of hypofunction. So when you're turning your head, how well are your eyes remaining fixated forward? We can do some measurements of that. And then for some people, it might help to see those numbers and say, you know what, it's actually not too bad. And, or it's within normal limits now, or we're making progress. And that should carry over functionally to these activities that involve looking at something and moving your head, for example, if you're driving. And that information will also help guide you in what activities should you do that involve changes of head position. So even if you don't measure that, you should still have a subjective sense of stability if that's improving. And so I think that's ultimately what Matt was coming back to. And on some level, Dr. Adunka, right? Can you do these activities while you're in a car, or for example, your other exertional activities with minimal sense of visual lag or imbalance? And just realize you'll have a little bit of that. Don't be too hyper focused on that. Allow that to be present. Your brain will naturally take care of it. And as far as really for most activities, there isn't really any reason not to do something that involves a lot of exertion, like weightlifting, for example. It's more activities that involve a lot of changes in head position, so sport or your plyometrics. And for each of those, it can help to talk to some of the therapists to break them down into smaller, more manageable activities, and then gradually build it back up.
And I've taken patients back through, like, return to running. I mean, it's a great VOR exercise. I mean, it has a lot of VOR stimulation. So if that's a prior level of function activity, right? Like if you were doing that before and, you know, that's one of your goals, like that's certainly reasonable to work on towards progress in therapy.
Yeah, Bora Dawson, she's the patient Dr. Adunka was meeting with yesterday, got back to snowboarding, even though it didn't seem likely she would. She's really motivated to do that. So if it sounds like whoever has asked that question has some interest and motivation in doing it, and that can definitely help. Really, I'm gonna back up. I know we're hitting towards the end of time, but that 3PD question, I do want to throw out a little plug that if 3PD is present, then it can be a little more challenging. Although if you've really not had that addressed yet, having some education can definitely help. But having education about what you're experiencing and why, as you're going through the process of having this acoustic neuroma, and what to anticipate after surgery, and sort of the outcomes you can expect, that can help relax all of us, right? If we feel comfortable, for me, quite honestly, even hearing some of these events, I certainly work with patients with acoustic neuromas, but even earlier in the week, hearing them, Dr. Adunka, Dr. Wren, Dr. Palmer, some of the others, just hearing them explain things makes me go, someone understands this and they're guiding me through it. And so we will have less anxiety and less likely to get into this chronic situation, which is essentially what your 3PD is. And so, so if you're having some imbalance and dizziness and concerns, then reach out and look for some guidance on that.
That's great. Thank you so much. We are really close to the end of our time. I had one last question. We talked yesterday or the day before yesterday, I think, about some alternative therapies, Dr. Wren with Dr. Kim, about acupuncture and chiropractic care and that kind of stuff. Does that offer any value here as far as vestibular therapy?
In terms of a evidence literature-based viewpoint, not to the best of my knowledge. I mean, I don't know all the evidence. I've always tell, anyone I work with that from a holistic standpoint, if you feel like that provides you relief on all these other secondary issues that you experience, then heck yeah, you should seek that out, right? Like if that's providing you relief, then you should pursue it. I always caution people on dependency, right? That if you're dependent on something that is like that, to get through your day, then maybe it's not necessarily the most beneficial for you. But, yeah, there's lots of, I mean, there's literature for acupuncture for a lot of different things out there, and less that I know from a chiropractic and vestibular standpoint, but I don't discourage it as long as people are using it the right way.
Okay.
We want to, yeah, with chiropractic kind of manipulations, we're just a little careful because, you know, there's also some potential real side effects in a negative way, right? So, but I think, Melissa, there's some other questions. Unfortunately, our time is up.
I know.
But Dr. Wren and I and Greg and Matt can probably try to answer some of these, you know, offline. I think.
Offline. Okay. Yeah, I can get
we're
those
happy
to
to do
you,
that.
and we have the contact, so we can definitely do that. I want to thank all of you for taking the time today, and thanks to everyone who attended today. This has really been an amazing awareness week because of all of you. Anybody who's attended a webinar, sent a photo or a story, shared our posts on social media, we're really grateful, and we couldn't do this without you. And thank you to all of the doctors who have joined us and taking so much time to put together these presentations, answer questions. All of our presentations are available on the ANAwareness Week page on our website. We'll get this one up as soon as possible. So I really do want to thank you, Dr. Adunka, Dr. Wren, for being here every day, and to all the other doctors as well for really taking a lot of time, being very thorough, answering so many questions. We're really grateful.
Our pleasure.
Thank you so much. I hope everyone has a great day.
Thank you.
Thank you.